there is amyloid in relation to Alzheimer's disease, but what is the true nature of it? It is pointed out that this protein may be closely related to aging. First, die as soon as you are, anyway, direly. Eating this prion-like protein fragment as a meal from an organism belonging to another species may be absorbed from the small intestine, enter the bloodstream of blood vessels, and become an infectious vector that destroys nerve tissue. No one knows what is an infectious agent. The mechanism of action and the cause of the disease are unknown, and nothing is known. However, as an indicator substance in aging research, there is strong interest especially in the field of neuropsychiatry. If you have a family, your family will be a close contact if your child tests positive for the PCR. In Japan, quarantine measures in workplaces and schools may also be tested by health authorities. In that case, you will be dismissed after waiting at home, and you will not be re-employed. There is a custom called Bushido in Japan. That is Bushido, or samurai code of chivalry, way of the warrior soul of samurai. However, most Japanese have no patriotism. Therefore, Japan peoples are not interested in elections. And also, even if Japan peoples would die, many Japanese cannot go to the hospital, which will select the double suicide or suicide together in the family suicide, a suicide of an entire family. At last, even among the families remaining. After all, in the near future, family joint suicides and killing of children are constantly happening in Japan. untraceable transmission route, and a highly infectious mysterious pathogen. Transmission route unknown, already too little, too late, infection route untraceable. But anyway, men tell no tales and the dead don't talk. Japan peoples will clean up their what they did theirself, or Japanese will take care of their own mess. That is Bushido, or samurai code of chivalry, way of the warrior soul of samurai. Foolish you, son of a bitch. Asshole. Son of the bitch. So it sucks, that's dumb, he's SILLYHOLY shit, fucking. Fuck, motherfucker, it sucks, of the bitch. Give you a sit rep. Kiss my ass. Go to die Japanese agent, let's go. Everyone sucker motherfucker. There is no any way out of those something else, I have no way out of as long as you're alive, you. Everyone have no way out everywhere from those, and also did that subconsciously, or sometimes unintentional. That was unintentional. Everyone commonly didn't mean to do that. There is no escape, no an exit, any exit of this living world, three-dimensional space, no way out of those some things. To be clear, no one in the world knows what an infectious disease is. In other words, there are many unpredictable uncertainties that will occur in the future. The pathogen may disappear spontaneously or become malignant. Looking at the epidemiological data, there is no record that applies to any existential data. Rather than logically normal, it is an abnormal situation, or an abnormal phenomenon. That is, it is an intentional abnormality. Looking at the infection distributions announced by the governments of each country so far, it seems that this is a deliberate phenomenon rather than a natural phenomenon. It has nothing to do with wearing masks, vaccines, effects, or social distance between people. The same phenomenon occurs accidentally and continuously at the same time in multiple events that leave a space that has no causal relationship. There is no answer to this. From the beginning, the origin of the coronavirus is irrelevant. However, the United States, China, and Russia are no longer in a position to turn back. There is no doubt that a new infectious disease is occurring. It is a mysterious infectious disease. The cause is unknown, there is no reason, and there is no answer. What's more, no one can predict tomorrow or the future. There are things that many people know, but cannot say. That is to avoid being treated as a national thief. No one is telling the truth. However, I dare to tell the truth on this occasion. There is no cold vaccine. From the beginning, there is no expiration date. The origin of the coronavirus is irrelevant. To be a treasonist or traitor. The situation is that there is no choice but to continue inoculating unclear vaccines. On January 9, 2021, Japan issued a state of emergency. The content was only a request for shortened business hours at a restaurant that serves alcohol, or a Japanese bar restaurant. A recommendation was requested at the administrative level not to open after 20 o'clock. However, those who go out tend to increase. Above all, there is no evidence. In Japan, paranormal phenomena have occurred frequently since 1990, and in addition to the psychic phenomenon, the neural circuits of the cerebrum are functioning in a state like a telepath phenomenon among multiple Japanese people on a daily basis. A mysterious unsolved murder case, a phenomenon in which a person disappears suddenly without leaving any trace, and a state in which multiple flying objects with unknown flight propulsion functions are flying over. They know who did what, and everyone knows and speaks out and no one says. This time, Japan is causing a phenomenon that causes a mysterious infectious disease at the planetary level, and it is a group of people who are in a more vicious state than China and North Korea. After this, we will leave the retaliation measures to the governments of each country. This has not been the case in any era left in history since the birth of mankind. Have that occurred in the 20th century has low infectivity. Most of the transmission routes are known to be sexual intercourse. In addition, antiviral drugs are being developed. Influenza virus, tuberculosis, and other infectious diseases, regardless of their infectivity or lethality, all follow the normal distribution of existing pathogens in the past in terms of location, duration, and timing. However, only COVID-19 is exceptional and different. Simply put, there is no end. No one knows why this infectious disease caused a sudden outbreak of infection last year at the planetary level. In other words, no one in the world knows, and no one knows. The cause is unknown. The worst scenario is that in the future, the possibility of an acute condition becoming malignant cannot be ruled out. One of them, severe inflammation of the lungs, destroys the alveoli. Tissue regeneration is difficult. In addition, the oxygenation of hemoglobin in the blood is blocked, resulting in immediate death from acute respiratory failure. Also, internal bleeding is also a problem. If bleeding occurs from systemic capillaries, he will die instantly. In many cases, they die silently during sleep, without any subjective symptoms. In that case, there is no cure in modern science. Humankind's are no longer possible to handle this phenomena just by chance unexpectedly. At this stage, the biggest problem for people all over the world is probably the pain associated with the inflammatory response. It is difficult to histopathologically examine the tissues of living human internal organs. However, normal cells are foreign substances even if they are asymptomatic, or have no subjective symptoms. Foreign matter expands in a plane, while ignoring the basic physics law of physical space and jumping over tissues. The inflammatory response can be rapidly exacerbated and can disappear rapidly within minutes to hours. During the daytime when the sun is shining from dawn, it is asymptomatic and has few subjective symptoms, but at night, when the sun goes down, a strong inflammatory reaction and severe pain occur, as of inflammation, and substances expand. There is no answer to this symptom of life on Earth. The symptom is known as an disease. Pathogens, whose source and route of infection are unknown, are, so to speak, continuous, chronic, or persistently progressing and spreading. If it occurs in the brain, blood vessels, lungs, or heart of the body, it can be fatal and cause sudden death. I don't know what the timing is. It has nothing to do with the immune system and is related to the time a person lives. When the pathogen invades the blood vessels and then enters the bloodstream, the gums in the oral cavity and the fibroblasts in the skin also show symptoms of inflammation. It is resistant to existing steroids and has a natural cure. Currently, the symptom of this infection is acute respiratory failure. A strong inflammatory reaction occurs over a wide area from the bronchi to the lungs. In that case, the lungs have a low regenerative capacity at the tissue level and are difficult to regenerate if the alveoli are destroyed. There is no cure and he has difficulty breathing and suddenly dies within a few days. Therefore, improving lung function, which is the first stage, is the first goal of treatment. Inflammation of the digestive system is also present. Epithelial mucosal cells of the digestive system regenerate tissue relatively quickly. Therefore, rather than dysfunction of the digestive system, disorders including pain remain for a long period of time. The actual condition of other organs is unknown, and since there is no pain nerve in the brain, there is no subjective symptom even if it is destroyed by a pathogen. Acute means that if no treatment or treatment is taken after infection, death will occur within a few days. The root cause of this condition is systemic inflammation that occurs after infection from the respiratory tract mucosa. Simply put, it becomes a foreign substance at the cellular level. There are discontinuous moments when humans are no longer humans rather than foreign bodies. Eventually, humans become a mass of foreign bodies at the cellular level, becoming zombies or biohazardous states. I don't know the cause. Apoptosis-inducing signaling usually occurs at the nuclear chromosomal level of cells so that tissues and cells are self-destructing when a disorder occurs from the normal state. At that time, immune cells are mobilized. After that, cell regeneration is probably caused by organ stem cells. The foreign body of this cell does not induce apoptosis. If the stem cells are destroyed, the tissue cannot be regenerated thereafter. This is not a sequela, but a typical symptom of persistent infections. First, there is no scientific evidence that the vaccine is effective. Therefore, symptomatic treatment is required until a therapeutic drug is found. In this series, we will first deal with the nerve cells of prostaglandins, which are the causative agents of pain. The mechanism of action of various anti-inflammatory agents, and what anti-inflammatory agents are effective for COVID-19 will be explained. And although there are individual differences, the prescription of general anti-inflammatory agents will be specifically described. Ibuprofen is one of the non-steroidal anti-inflammatory drugs classified as propionic acid. Known under the brand name Brufen in Japan, it is widely distributed not only for medical purposes, but also as over-the-counter drugs. It is used to relieve the symptoms of arthritis, menstrual pain and fever, and to relieve inflamed areas. Like aspirin, it is said to be due to the inhibitory effect on prostaglandin, PG, synthesis by inhibiting cyclooxygenase activity. It has antipyretic analgesic and anti-inflammatory effects, and especially has a strong peripheral prostaglandin synthesis inhibitory effect. So it is effective for pain accompanied by peripheral inflammation such as upper respiratory tract and arthralgia. Ingredient, generic name, acetaminophen. Product example, Carinol tablets 200, 300, 500, Carinol fine granules 20%, 50%, Carinol syrup 2% other, generic, and drug price. Category, antipyretic analgesic, and anti-inflammatory and aniline non-pylon antipyretic analgesic. A proven and safe antipyretic analgesic. It is an aniline drug and has a different mechanism of action from general analgesics called NSAIDs. Compared to NSAIDs, the effect is gradual, but there are few side effects, and long-term use is relatively safe. For this reason, it is positioned as the first stage of the WHO three-stage pain treatment method and is widely used overseas as a basic drug for various types of pain. It may not be suitable for severe pain with inflammation, but it can be applied to a wide range of mild to moderate pain. Another advantage is that it is old and inexpensive. It is often used as an antipyretic in Japanese hospitals. It is prescribed for fever and headache-related colds and flu, and is also induced fever. In 2010, the indication of osteoarthritis was added, and a dose increase of 1,000 mg at a time, and a total daily dose of 4,000 mg was approved. In Japan, a relatively small amount was often used, but using a large amount can be expected to enhance the analgesic effect. In the future, there will be more opportunities to be prescribed as an analgesic, including in the field of orthopedics. Prostaglandins, PG, are substances that cause inflammation, pain, and fever in the body. In the body, PG is produced from a substance called arachidonic acid by the action of an enzyme called cyclooxygenase, COX. In addition to being a factor that causes inflammation and pain, PG sends a command to the thermoregulatory center in the hypothalamus of the brain. And the thermoregulatory center that receives this command instructs each part of the body to raise the body temperature. This causes heat generation. Non-steroidal anti-inflammatory drugs, NSAIDs, suppress the production of PG by inhibiting COX and show the effect of suppressing pain, inflammation, fever. Ibuprofen is one of the NSAIDs drugs that suppresses PG production, thereby exhibiting anti-inflammatory and antipyretic analgesic effects. Typical drugs that inhibit both COX-1 and COX-2 include ibuprofen, piroxicam, and aspirin. Acetaminophen has nothing to do with the analgesic effect that depends on the action of an enzyme called cyclooxygenase, COX. The pharmacological mechanism of action of acetaminophen is in the research stage and details are unknown. Next time, I will explain about anesthetics.
Hello everyone, welcome to Scadia.com. Our topic for today is prostaglandin. We are at section 5 of this topic. In our today's section, so far we have discussed in detail about prostanoids, and in prostanoids we've discussed all about prostaglandins. So now we'll move on to the other two types of prostanoids, that are the prostacyclin and the thromboxane. We'll see what is the difference between prostacyclins and thromboxanes, and then we'll move on to other prostaglandins or other eicosanoids that are the leukotrienes and lipoxygens, and we'll see their functions and their role in your body as well. So starting with the prostacyclins versus the thromboxanes. Both of them are prostanoids. Both of them have a somewhat similar structure. The difference starts when the prostaglandin G2 is converted to prostaglandin H2, and then there is an enzyme involved that can either be the prostacyclin synthetase or the thromboxane synthase. So if it's thromboxane synthase, then it'll obviously form thromboxane A2. And if it's prostacyclin synthase, then it will form prostacyclin. And so they'll have different functions. They have different types of receptors on different cells. And interestingly, prostacyclins and thromboxanes have functions that are entirely opposite to each other. So if you look here, you can see there is prostacyclins that are produced and the thromboxanes that are produced. So this is the thromboxane synthase and the prostacyclin synthase, and both of them are formed from the prostaglandin H2. So once the prostacyclin is produced and the thromboxane is produced, they will be hydrolyzed and they'll form 6-keto PGF 1-alpha. This can then act on different levels. They can act on your renal cells, etc. They can act on your liver, lungs, and kidney enzymes. And then there is thromboxane, as you can see here. And then at this once the thromboxane produces alpha dehydrothromboxane, then it has a more systemic role than renal role. And similarly, in this case, it has more systemic role than renal role. If you look at the figure that I've given here, prostacyclin is produced. It can further form 6-keto prostaglandin, as I've said here. This is the 6-keto prostaglandin F. 1-alpha, and this is the 2,3-dino-6-keto prostaglandin F1-alpha. Similarly, thromboxane produces thromboxane B2, 11-dehydrothromboxane B2, and 2,3-dinar thromboxane B2. There are different receptors on liver, lungs, and kidneys that are either receptors for prostacyclin or for thromboxane. The receptors that are present for prostacyclin will bind to the prostacyclin molecule, and there will be initiation of vasodilation, expression of adhesion molecules, chemotaxis, and platelet aggregation. So it means that prostacyclin will cause all of these. But when we're talking about thromboxane, you can see thromboxane causes vasoconstriction as opposed to vasodilation that is caused by prostacyclins. It increases the expression of adhesion molecules, and it increases the platelet aggregation and proliferation. So there's a decrease in chemotaxis, platelet aggregation, and decrease in expression of adhesion molecule. And here there is vasoconstriction, increase in expression of adhesion molecules, and increase in platelet aggregation. So I think I mixed them initially, but the basis is prostacyclin is a vasodilator and the thromboxane is a vasoconstrictor. So prostacyclin is going to decrease the chemotaxis and platelet aggregation and expression of adhesion molecules, and the thromboxane is going to increase the expression of adhesion molecules, the platelet aggregation, etc. So moving on to the applied aspect of the prostacyclins and thromboxanes, they are used for the prevention of thrombus formation. So platelet releases the endoperoxides, and the endoperoxides then are converted to prostacyclin or the PGI2. The PGH2, by its vasodilation effect and inhibition of platelet aggregation, this is exactly what we have discussed earlier. It's a vasodilator, so it will inhibit the platelet aggregation, and it will repel the platelet and prevent them from sticking together and forming a nidus. So this totally opposes the thromboxane activity, where you can see that thromboxane is a vasoconstrictor, and it will increase the aggregation of platelet and will ensure them sticking together to form a nidus. So the function is entirely opposite to that of thromboxane. So balance between these two biochemical processes is critical for the formation of thrombus, and so the level of thromboxane and the level of prostacyclin just ensures the thrombus formation. Similarly, you can see here, this is again an applied aspect of prostacyclins and thromboxanes. There is a vascular wall injury, circulatory status, and hypercoagulable state in which you either need thromboxane to function more, or you need the prostacyclin to function more. So these are the three major states where we can actually utilize these for therapeutic purpose. Injury to blood vessel wall decreases the formation of prostacyclins. So if your blood vessels gets injured, there will be decrease in prostacyclin formation, because of which there will be decrease in the anti-coagulatory action of prostacyclins. Unopposed to thromboxane, in such cases, platelet aggregation and thrombus is formed. So your blood vessel is injured. That will cause the decrease in prostacyclin formation. So it means, since prostacyclin opposes the aggregation of platelet, but now the level of prostacyclin is decreased, so it means that there will be more platelet aggregation. So that means that there will be more chance of thrombus formation, because thromboxane is performing its function and the level of thromboxane hasn't decreased. And so that's important, because it will stop the blood flow, and in case of injury to blood vessels, thrombus will be formed. Then the other type of prostaglandins that we are going to discuss are the leukotrienes. Leukotrienes are basically from a group of from the family of conjugated trienes, and they are also formed from eicosanoic acids, versus through the lipoxygenase pathway. So that's what I discussed earlier as well, that the eicosanoic acid is the precursor for all of these molecules, but when we are talking about leukotrienes are formed from the lipoxygenase pathway, as opposed to the cyclooxygenase pathway, through which all the prostanoids were formed. So they possesses no rings in their structure, so that's what makes them different. They have three characteristic conjugated double bonds, and they are synthesized from the arachidonate by the addition of hydroperoxy groups in them. So as you can see here, arachidonic acid is acted upon by lipoxygenase, and it forms leukotrienes, which include leukotriene C4, D4, and E4. And they have different functions in plasma exudation, mucus secretion, bronchoconstriction, and the EOS recruitment, etc. And then there are different drugs that act as inhibitors. As you can see, these are all the drugs that can inhibit the function of leukotrienes. They produces the hydroperoxy eicosa tetranoids, also known as HPETE. So leukotrienes will be formed by the addition of the hydroperoxy group to the arachidonate that will form HPET. There are different types of HPT that are formed from that will form different types of leukotrienes. There is a 5-HPT. This is the most common type of HPT. The major product of 5-lipoxygenase reaction in the polymorphs, basophils, mast cells, and macrophages. And then there is a 12-HPT, which is the product of 12-lipoxygenase and occurs in platelets, pancreatic endocrine islet cells, and the glomerulus cells of the kidney. And then there's finally 15-HPT, which occurs in reticulocytes, eosinophils, and T cells, and this is the product of the 15-lipoxygenase. So it means that the type of lipoxygenase will help us differentiate the different types of HPT. Also, the function in the tissues where they perform is different. That is, some are present in the macrophages and mast cells, and other are forms in the endocrine islet cells and kidney cells, and where others are finally formed in the T cells, etc. So these are the number of functions that the leukotrienes perform, from activating an invasion of metastasis to sustaining proliferative signals, evading immune destruction, tumor promoting inflammation, evading growth suppressors, resisting cell death, deregulating the cellular energetics, genome instability and mutation, inducing angiogenesis, and enabling replicative immortality. The roles that are identified in all of these are different groups of leukotrienes that perform different roles. There is no specific role identified in case of evading immune response or enabling replicative immortality, but certain researchers think that leukotrienes do perform their role here as well, in these particular cases as well. Then the other type of conjugated tetraenes is the lipoxins. There are several types of lipoxins. They are lipoxin A4 to E4. They are formed by the lipoxygenase, and they introduce more oxygen to the molecule of the arachidonic acid. So they're somewhat similar to the leukotrienes, but there's more oxygen in the molecule of lipoxin as compared with the leukotriene. Here you can see there is a lipoxin A4 that is formed, lipoxin B4 that is formed, and they're all formed from leukotrienes, as you can see here. So this is the structure of lipoxin A4, and this is the structure of lipoxin B4. So lipoxins are vasoactive, and they have different immunoregulatory function in your body. You can use lipoxygenase system because it's not inhibited by aspirin, as we have discussed in our previous sections, and it's not blocked by other anti-inflammatory drugs. So you can, there is a prolonged use of aspirin that is known to depress the cyclooxygenase system and the prostaglandin synthesis, but it enhances the lipoxygenase system and the synthesis of leukotrienes, which leads to bronchospasm and produce aspirin-induced bronchial asthma. So it means that if you're using too much of aspirin, you're actually depressing the cyclooxygenase pathway, and you are enhancing the lipoxygenase pathway, which will result in the production of more leukotrienes and lipoxins, but less of the prostaglandins. This can lead to bronchospasm and aspirin-induced bronchial asthma. So that's how you can see here there is stimulated platelets because of thromboxane, and there is an anti-inflammation or pro-regulation because of leukocytes. So these are different functions of aspirin, for example, as you can see here. It inhibits this thromboxane production, and here it increases the production of leukotrienes. So these are the applied aspects of both of these molecules. Similarly, it's a lipoxygenase inhibitor. The lipoxygenase inhibitor is the leukotriene before. It plays a key role in causing an amplification of mucosal injury in ulcerative colitis. Xalutone, which is a selective 5-lipoxygenase inhibitor, is being used to study for its therapeutic use or therapeutic efficacy in the ulcerative colitis because it blocks or inhibits the lipoxygenase. So it'll block this. We know that lipoxygenase isn't going to be blocked by aspirin, so you need xalutone to block the lipoxygenase and use this particular therapeutic efficacy for ulcerative colitis. So in this section, we covered other members that are part of prostaglandins. We studied leukotrienes, we studied lipocyclins, and we also studied lipoxins and thromboxins, and we saw how their functions varied from each other, but they are present in almost every muscle of your body and they're performing different functions, and scientists, researchers.
The chronic perfusion state of the brain, we are beginning to learn, can also be a marker of chronic pain. So we've in the second talk we explored the methods behind functional MRI, and we saw how the transient bulge response, the transient increase in cerebral blood flow, is a marker of acute pain. However, we now have techniques, non-invasive techniques, in the MRI scanner which allow us to measure perfusion over the time course of minutes and then to compare that perfusion from day to day and from month to month. This is known as arterial spin labeling and gives us a measure of the brain state. The technique works by magnetically tagging blood as it flows up through the neck into the brain. We record the arrival of this blood in the brain, and the image intensity that we see gives us a measure of the amount of blood that has got to each brain region, or the cerebral blood flow. And we can produce maps like this, where the brightness of the colour indicates the amount of blood going to that particular brain region in mils per 100 grams of brain tissue per minute. So you can see, as we would expect, there's much greater perfusional blood flow to cerebral grey matter and deep grey structures than there is to white matter, which has a much lower metabolic demand. We can zoom in on particular slices here and pick out some of the structures, for example, insular cortex and sensory cortex, that we are interested in identifying the state of in a chronic pain condition. Now, very recently, the first studies have been published looking at pain models with these perfusion techniques. And this is a study of muscle pain in healthy volunteers, pain lasting several minutes, with the injection into the muscle of a hypotonic solution causing...
Le Depot is an iconic nightclub for gay partygoers in Paris. It's been closed for nearly a year, but this weekend it's reopened as a venue to carry out COVID-19 tests. One of the DJs who plays at the club said screening people was the route out of the pandemic.
Pain activity that we've seen in
It reminds us that at one time there were also places where people lived in Paris, and that they're motivated to help things get better, and also to amplify screening, which is becoming essential to getting out of this pandemic.
Primordial pour pouvoir sortir de cette pandémie.
Clubs in London are also wanting to help, despite their own desperate position. According to the Save Nightclubs Coalition, the industry generates more than €3 billion a year for the UK economy and employs 45,000 people. We have the places, we have the buildings, and if we can help in some way, we'll try to do it. If we can help COVID to disappear, it's very good for us. Meanwhile, other entertainment venues are already up and running. The famous London cricket club Lords has been a vaccination centre since mid-January. Its spacious facilities have been ideal, and it's now the largest vaccine centre in its district.
Hello, I'm Richard Wise, and I'm Director of Functional MRI at Kubrick. That's the Cardiff University Brain Research Imaging Centre. And I've been studying pain using human neuroimaging techniques for about the last 10 years, mainly with Professor Irene Tracy at Oxford University. So lots of the slides that I'm going to use come from her group, so I should begin by acknowledging those. I'm going to give a series of 5 short talks on human pain studied with neuroimaging. The first of these, why should we want to image pain in the human brain? Secondly, pain imaging methodology with a particular focus on functional MRI. Imaging experimental pain in human volunteers. Number 4, imaging real pain, dissecting the pain experience of clinical patients. And number 5, the latest developments in pain imaging techniques and experiments. So to begin with part 1. Why do we want to image human pain? Pain, as I'm sure most of you are aware, is a major medical health problem across the world. Chronic pain that persists or occurs for more than 3 months is one of the largest medical health problems, particularly in the developed world, and affects about 20% of the adult population, particularly women and the elderly. In Europe, the estimated cost is around 200 billion euros per year, and in the US, 150 billion per year. Management and treatment of chronic pain is a largely unmet need, and innovative methods are needed to challenge this problem. But can imaging aid in diagnosis? Well, this to some extent is an unanswered question as of now, but there's a plethora of research methods that are now available to look at human brain activity related to pain, including functional MRI, structural MRI, looking at how the shape and size of the brain changes, positron emission tomography or PET, EEG, electroencephalography, and MEG, magnetoencephalography. These techniques aim to examine the functional and structural changes in the brain associated with the pain experience, and also to try and illuminate some of the central nervous system mechanisms that can contribute to a chronic pain state in patients. And this is the frontier which is currently being pushed at in the research world at the moment. And we hope also that imaging will give us a better understanding of the interrelationship between nociception, that is the reception of noxious stimuli, and the pain perception itself. So just a brief outline of this current talk. We're going to look at what pain is, how we can use imaging to look at the different dimensions of pain, the networks of brain activity that have been identified, and then briefly how imaging can be used in drug development. So what is pain? The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Well, that sounds relatively simple, but pain is a multi-dimensional experience. Descartes' original description in 1664 of a single pain pathway, shown here by this cartoon, a single pain pathway from the foot up to the head, we now know is an oversimplification. Still, one of the most common ways that we have of measuring pain is to ask people about pain intensity that they're experiencing, and obviously this, in some senses, has to be a gold standard. The subjective experience of pain is the phenomenon that we're interested in measuring and what we're discussing today. So here is an example of a typical 11-point numerical rating scale with 0 marked as no pain and 10 pain as bad as it could be. But nociception, the process of receiving noxious stimuli and sensing those stimuli to the body leading to pain, is a very complex experience. And how much pain is experienced depends on all sorts of different things, as we're trying to illustrate here in this diagram. It depends on the context of the pain, the person's beliefs, their expectation, placebo effect, the cognitive set, hypervigilance, attention, distraction, long-term catastrophizing, for example. And these factors can be described in terms of psychological language, but also increasingly in terms of neurophysiology and the concepts of central sensitization, top-down control from the cortex, and feedback within the central nervous system. We have several, as I've described, we have several techniques available now to give us a window into the central nervous system. And of course, most of these emotional and cognitive factors associated with pain, those effects are naturally going on in the brain. They're centrally mediated. So this is where functional brain imaging comes in. It allows us to integrate and interrogate human central nervous system activity non-invasively. So how do we start to image these different dimensions of pain? Well, let's just focus on one to start with, central sensitization. If we consider tissue injury, tissue damage, there's naturally peripheral activity associated with that, and that can lead to a central sensitization, both spinal and supraspinal, resulting in hyperalgesia, spontaneous pain, allodynia, and an expansion of the receptive field of pain around the injury. Imaging and indeed older experiments in animals have obviously demonstrated the important role of the brainstem in pain processing, and particularly in its anti and pro-nociceptive mechanisms which it displays, being involved in top-down control of pain, bottom-up sensitization, in addition to changes that occur in the dorsal horn of the spinal cord. So one particular area of interest in the world of imaging has been looking at central sensitization as an amplifier of the pain experience, and we'll see in a later talk how capsaicin is used in healthy volunteers as a model of secondary hyperalgesia, with associated increases in activity in the brainstem as shown here on the right hand side. Dr. Irene Tracy's group in Oxford has also conducted studies using gabapentin to modulate this central sensitization state, looking at capsaicin cream in healthy volunteers, and again we'll go through this experiment more in one of the later sections of the talks. But just to summarize, the brainstem showed significant increases in activity with this hyperalgesic state, with this capsaicin model, that was then significantly decreased by the application of gabapentin, this drug commonly used in neuropathic pain conditions. But context of pain also has a big influence, as we all know from daily life. Here's an example from the rugby field. Why does this tackling of this French player, why doesn't it hurt? It would hurt most of us. But this is in the context of a rugby game. There's all sorts of factors at play here: culture, fear, probably lack of fear, distraction, the reward of the match. So these violent activities don't appear to hurt, not at least at the time. And the imaging techniques that we use are starting to shed light on how these top-down, these mood-related control mechanisms can affect the pain that's experienced. Something that we see by observation in everyday life. For example, again, a study from Irene Tracy's group, one of her earlier studies, looking at the attentional modulation of pain and how a brainstem region, the periaqueductal grey or PAG, seems to have an effect in decreasing the pain that volunteers experience. So in response to an experimental thermal pain, volunteers were asked to either pay attention to that stimulus, to attend to it, or to try and ignore it and not attend to it. And when they tried to ignore it, the perception of pain, the intensity of pain that they felt, was reduced in line with activity in the periaqueductal grey, which supports the idea that this region of the brainstem has an effect on the control of pain signals coming up into the brain, the descending inhibitory system as we know it. So imaging in recent years has played a role in identifying the brain's pain networks. And there's now a collection of regions illustrated in this diagram which are associated with acute and also persistent pain processing. shown on the left-hand side. And the hard core of these regions, the ones that pop up in most imaging studies, include sensory discriminative regions, for example, the primary and secondary sensory areas, S1 and S2, the thalamus. And then there are the more effective cognitive motivational regions of the brain, prefrontal cortex, anterior cingulate cortex, which seems to be involved in attention towards pain, and also, importantly, the insula, which appears to have several dimensions, a role in monitoring the internal state of the body. So these imaging studies have been matched up with previous studies of connectivity between different parts of the brain to produce what lots of pain researchers like to call the pain matrix, although this terminology is going slightly out of fashion now as people try to get away from the idea of labeling specific parts of the brain being responsible to pain and looking more at the interaction as a network of different brain regions, because it's becoming increasingly clear that different components of the pain experience will modulate different parts of that network in different ways. So finally, just a concrete example of how imaging can be used in drug development, for example. This is something that we're involved in at Kubrick at Cardiff University. What we have here on the top row, you can see a series of spikes which are the response to a thermal stimulation in the insular cortex. We conducted an experiment using remifentanil, a mu-opioid agonist, a potent compound used during surgery. And during the grey periods here, you can see the amplitude of the pain responses decreases as the drug takes an analgesic effect. Now we can measure the time course of activity of that drug, so we can measure how fast it's having an effect in the brain and how fast that effect is wearing off. We were able to model that time and establish these so-called pharmacokinetic time constants of the drug activity in the brain. And of course this is of interest when developing new compounds, not only to the drug industry, but also to clinicians interested in how long the drug is actually having an effect in the brain. So functional MRI, as well as one of several neuroimaging techniques, can be used in the drug discovery process, and this really mirrors our research interests across the whole range of pain research. Both it can be used as a basic neuroscience marker of pain activity to understand pain processing in the brain, but it can also be used to assess how drugs or other interventions are modulating the pain experience. So just to summarize this first talk, pain is multidimensional. It's not simply the reception of painful signals or signals that have the potential to cause the animal harm. Not just nociception, it includes a multidimensional series of factors, emotional, cognitive, affective, etc. Imaging helps us to understand the mechanisms associated with pain processing, neurophysiological and psychological, allows us to study adaptation and maladaptation to chronic pain. Perhaps it will allow us to stratify patients to help decide on their future treatments, and we're already beginning to use imaging to drive the direction of new therapies and to understand how things like cognitive behavioural therapy and pharmacological interventions can modulate the pain experience. Finally, I'd just like to acknowledge for this talk Professor Irene Tracy and John Brooks of Oxford University for providing me with some of the slides. Thank you. Hello, I'm Richard Wise, Director of Functional MRI at Cardiff University Brain Research Imaging Centre, and this is part 2 of 5 short talks on neuroimaging human pain. So in the first talk we heard about why we would want to use imaging to try and understand pain mechanisms in the human brain. The second part here we're going to look at pain imaging methodology and some of the technology, particularly functional magnetic resonance imaging, that lies behind these particular experiments. So we're going to start by looking at some of the tools to examine nociception and pain itself. I'm going to then tell you about the technology behind functional magnetic resonance imaging based on MRI, and then just mention briefly a couple of electrophysiological techniques, EEG and MEG. Now, this is a schematic representation of the human nociceptive system. Nociception being the detection and reception of stimuli that can be noxious to the animal, and of course there are peripheral nociceptors which feed into the dorsal horn of the spinal cord, ascending pathways through the brainstem, and then into the traditionally regarded as the medial and lateral pain systems. Now, there are specific peripheral nerve fibers coding for different types of offensive stimulus in the periphery. We know that in the brainstem and in the spinal cord, signals summate and there's a degree of plasticity, sensitization can occur. But it's really in the brain where we believe that pain itself is integrated. So these unpleasant, noxious stimuli coming up the spinal cord through the brainstem into the brain, combined with the unpleasantness, learned experiences, other factors, cognitive, emotional factors, combine to produce the experience that we call pain itself. Now, what tools do we have to study human pain in the brain? Well, down on the right-hand side here is a list. Neuroimaging is naturally concerned with what's going on in the brain, although we'll see a bit later on that we can also look at the brainstem and increasingly these days the spinal cord in an integrated manner across the whole neuroaxis. Behaviour mustn't be forgotten. I mean, in the light of all of these fancy technologies that you're about to see about, we shouldn't forget that behaviour, how painful, and psychophysics, how painful the experience is, must always be compared with these physical measurements which we're making. Electrophysiology still has a large role to play in examining the mechanisms, the function of peripheral nociceptors, and indeed in animal experiments in the context of the mammalian pain system. And finally, molecular biology and genetics has an increasing role to play these days, both interacting with human brain imaging, the influence of genetics on how pain is represented in the brain, but also at the molecular level, pain targets for pharmacological treatment, for example. So neuroimaging is one relatively new tool in the toolbox for examining human pain. There are others which shouldn't be forgotten about. So the technology, I'm just going to walk you through some of the technology that we have available at Kubrick, also available in other imaging research centres around the country and around the world. The key ones in our centre are magnetic resonance imaging, magnetoencephalography, and electroencephalography. So what I'm saying about Kubrick could apply to other research centres around the UK, for example in Oxford, Irene Tracy's group in Oxford, the Institute of Psychiatry with Steve Williams in London as well. So we have a 3 Tesla MRI system, twice the magnetic field strength of a normal clinical MR system, housed in a purpose-built centre. We have an MEG system, magnetoencephalography, detecting the magnetic fields generated by the brain. We have EEG, detecting the electric potentials produced by nerve cells in the brain. And also another technique which you may not have heard of, transcranial magnetic stimulation, which allows us to temporarily interfere with cortical processing to look at causality of function within the cortex. And finally, these days a high-performance computer is necessary to crunch all of the data that comes in from these various different imaging techniques. But functional magnetic resonance imaging is the area in which I mainly work, and which I'm just going to focus on for the next few slides, describing to you how this technique works. And it's something that's been around now for approximately 15 years. In the last few years, increasing numbers of universities, Cardiff included, have opened their own imaging centres with functional MRI facilities for looking at all sorts of brain functions, not just pain, cognitive functions, basic sensory processing of vision, for example, as well. Now here is an example of the typical kind of picture that you might see resulting from a functional MRI study. On the left, we have cross-sections through the brains of healthy volunteers. These volunteers have been given a noxious heat stimulus, a painful heat to the back of the left hand, not enough to cause tissue damage, but enough to be perceived as painful. On the top left is the pattern of brain activity associated with the basic stimulus, and then we give increasing, in this experiment, which I'll talk about more in the next talk, we've given increasing doses of an opioid, remifentanil, which we can see is reducing the amount of brain activity associated with pain. The pain-related activity is shown in red and yellow, typically as blobs on top of this grey structural scan, which you can see in the background. And the amount of pain activity is decreasing as the perceived pain intensity also goes down. Now, where do those blobs come from? How do we generate those images with the colours on them? What we're aiming to do is to measure with functional MRI neural activity. But actually what we measure is some distance away from neural activity. We're actually measuring changes in blood oxygenation and blood flow within specific parts of the brain. Now those changes arise because there's an increase in metabolic activity within the brain tissue, increased cycling of neurotransmitters requiring energy across the synapses. So functional MRI relies on this hemodynamic response, the increase of blood to provide oxygen and nutrients to increasingly active brain tissue. But naturally, the other techniques that look at brain activity rely on other aspects of this of these functional changes. So EEG and MEG aim to look at the electrical changes of nerve cells more directly. Positron emission tomography can look at metabolic responses by labeling glucose or oxygen. But functional MRI relies on non-invasive imaging techniques and sensitizes the MRI scans to changes in tissue oxygenation. The different imaging techniques have different benefits, different strengths and weaknesses. On this two-dimensional plot here of the different functional mapping methods, you can see a comparison of the spatial resolution of the different techniques versus the time resolution of the different techniques. So, for example, MEG and EEG electrical techniques have very good time resolution. We can measure changes in brain activity over the time scale of milliseconds. Functional MRI, because it relies on the brain's plumbing, relies on changes in blood flow, however, is a bit slower, so we're only sensitive to changes over the course of a few seconds. Spatial resolution is slightly better in functional MRI than it is for positron emission tomography or the electrophysiological techniques, but obviously it's not as good as the single unit recordings which are down at the cellular scale. So different techniques give us a different window onto pain processing. But this nice electron micrograph just serves to remind us how the functional MRI signal arises from changes in blood flow and blood oxygenation. And this is something that we shouldn't forget when we're trying to interpret functional MRI signals and changes in brain activity related to pain. So a little bit more about how that signal arises in our MRI scanner. And the most common form of functional MRI is called bold functional MRI. Bold stands for blood oxygenation level dependent. And in this schematic you can see the final production of a bold signal over on the right hand side. But what we're really interested in is neural activity on the left hand side, so the transmission of signals around the brain, the synaptic signaling. So there are several steps in between this neural activity and the functional MRI signal which we measure ourselves. Those involve neurovascular coupling, so there's a metabolic cascade, a series of metabolic signals, and also neurotransmitter signals which generate a vascular response, increasing blood flow locally at the capillary level to capillary beds to water the brain with increased oxygen and increased nutrients. This produces what we call a hemodynamic response, and you'll hear people talking about this in the world of functional MRI. So in response to a neural stimulus, for example, a noxious external pain stimulus, or perhaps a faulty, as we'll see later on, a faulty signal from a neuropathic pain condition, the neural response elicits this metabolic oxygen increase, demand in oxygen increase, and also a blood flow response to try and cope with that. The amount of blood volume in a particular brain region also goes up, and perhaps counterintuitively, the amount of deoxyhemoglobin in a particular brain region goes down. So what we're saying is that more oxygen is being supplied to a particular area that is active, and that increase in oxygen produces this signal change in the scanner of approximately 1%, and this is known as the bold response. Now 1% is fairly small, and it's around the same level as the noise in the data. So we tend to have to scan people for several minutes to accumulate enough data, to average enough data together to become sensitive to the pain signals that we're interested in. Well, how does this oxygenation-based signal arise? An oxygenated red blood cell has very similar magnetic properties to the rest of the tissue around it, whereas a deoxygenated red cell is what's known as paramagnetic. And as you can see here, it behaves like a small magnet once we place the subject, the volunteer, the patient inside our MRI scanner. That magnetic property disrupts the field, the magnetic field around the blood vessels. Some results for that simulated here. And this disturbance in magnetic field around the blood vessels destroys some of our MRI signal. So when we flood these parts of the brain with extra oxygen, we actually get a small increase in the MRI signal. And what's happening is that the blood flow is much larger than the increase in oxygen consumption that's required from the pain-related activity. So, for example, if the amount of oxygen that's required goes up by 10%, the amount of blood flow increase may be, for example, 20%. This is how we end up with, in the end, an increase in the degree of oxygenation of blood in that brain region. So, how do we turn these physiological changes in blood flow into signals which we can measure, and then we can make conclusions about what's going on with pain? Well, I'm just going to illustrate this with a very simple example. First, some of the first experiments that were done with function MRI involve the visual system. What we have here is a flashing checkerboard on the screen. We essentially flash lights in the eyes of the volunteer, stimulating the visual cortex. Now, if we look in a particular part of the brain that responds to visual stimulation, when we switch that stimulus on and off every 30 seconds or so, we modulate the blood flow in the brain in that region up and down. Now, this bold signal, blood oxygen level dependent signal, is always a relative measure. So we're always, within an experiment, we always need to introduce two conditions, an on state and an off state, so that we have a contrast. We can look at changes in brain activity, the principle of subtraction, of adding one stimulus on top of another. And the sensitivity of our experiment depends on maximizing that relative change between the on and the off responses. Now, that's all very well in the context of human experimental pain. When we have healthy volunteers and we want to look at the basic function of the pain system, we can apply well-controlled pain stimuli and switch them on and off with whatever time resolution we want to. However, when it comes to clinical studies, these are still relatively limited in number in the field of function MRI, although increasing, because of the difficulty in switching the pain on and off. If we were able to switch the pain off, then there wouldn't be such a clinical problem with pain as there clearly is. So we have to be a bit more clever in some of these clinical studies, either trying to provoke the patient's pain to get a contrast between less painful and more painful, or, as we'll see later on, employing slightly different imaging techniques which look more at the state of the brain. Well, assuming that we can do a functional MRI experiment, we produced what are called statistical parametric maps, or SPMs. Now, this is simply a summary measure of where the signal has changed in the brain in response to the stimulus, and we would tend to produce this result by acquiring scans with the stimulus switched on and off for, say, perhaps 10 minutes, We compare the on phases with the off phases, and we perform a statistical test between the on and the off and a threshold, and we then overlay a map of where there are significant changes in signal on a high resolution structural scan of the brain. So this is where you see these locations of activity marked on top of a high resolution T1 weighted structural scan of the brain. Very often, as well as looking at functional responses in individual subjects, we want to make some conclusion about a group. So normally, functional MRI studies will include a cohort of perhaps 12, 15, 20 volunteers or patients in order to produce an average result and say something about the population behaviour of the group that we're interested in. So this technique's been around for 15 years. It's expanded a lot in the last 10 years in terms of number of centres. What kinds of questions can we address with functional MRI? Well, here's a list of them. Where is the function likely to be? So we can map the brain for functional specialisation, different parts of the brain doing different functions. We can then go on to ask whether our neuroanatomical models are likely in the context of the particular experiment that we're doing. So if we hypothesize that a particular brain region is involved in an emotional aspect of pain, we can begin to identify that by modulating the factors within our experiment. We can look at how the functional pattern changes with intensity and with the perceived level of the pain, and also look at the modulation of those functional changes with disease, drugs, training and learning, and look at long-term changes known as cortical plasticity. There's an increasing interest in understanding what the brain is doing at rest. The brain is rarely at rest, and it looks as if there are coordinated regions, coordinated networks of brain activity, even when we don't present specific tasks to volunteers or patients, and these networks can be modulated, it seems, by the existence of a chronic pain condition. Finally, we can look more at the neurophysiology, how the electrical activity in the brain compares with this blood flow response, and also relate function to changes in structure, as you'll see in one of the later presentations. So these neuroimaging techniques, and particularly functional MRI recently, have produced this neuroanatomy of pain processing, these different regions which are engaged in processing different facets of the pain experience. Just a couple more examples of that. Here's one study from John Brooks from 2002 looking at distraction and the role of the insular cortex. And what we find is that the insular cortex, for example, itself seems to be partitioned into slightly different functions. The anterior insula on the right-hand side seems to be much more concerned with the internal monitoring of the pain state, so is highly modulated by distraction, whereas the posterior insula showed most activity on the side contralateral to a thermal stimulus, and was less modulated by attentional factors. So imaging, the insula is one region of the brain where imaging seems to have shed a lot of light onto its function, and Bud Craig has published reviews and original studies on the role of the insula as a region for monitoring the internal state of the body, and this is changing some of our initial views on the segregation between the medial and the lateral pain system, to the extent that the insular cortex itself seems to exhibit a degree of somatotopy. So there seem to be body part related different positions of activity according to the part of the body that is stimulated. Again, this has been investigated by John Brooks in 2005. Finally, I'll just say a few words about the electrophysiological techniques. And one thing to bear in mind when we look at these different techniques is that they give us a slightly different window onto brain function, because they're measuring the electrophysiology, not the blood flow. So in this case, laser stimulation in conjunction with MEG, magnetoencephalography, gives us sources of activity in primary sensory cortex, as we might expect, contralateral to the stimulus, but bilateral also in secondary sensory cortex. And the activation seems to correspond well with the perception of pain. However, that's not necessarily the complete story. In this functional study using laser pain, we can see that actually when the pain is applied to the right-hand side of the body, the hand and the foot in this case, the foot being depicted in green and the hand in red, we actually get some degree of bilateral activity. So the unilateral nature, the contralateral nature of pain activity in the primary sensory cortex is not complete. Finally, EEG can also be used to look at specific pain events, and we've done some work examining EEG responses to a laser where there's a strong vertex potential between about 200 and 300 milliseconds following the laser stimulus, and this to some extent codes pain intensity, but also other factors such as attention and the saliency of the stimulus. This, beyond evoked responses in magnetoencephalography and EEG, pain can also modulate ongoing oscillatory activity, and Marcus Ploner has investigated this and published in Cerebral Cortex the modulation of high frequency, that's gamma activity around the 20 hertz and higher frequency band in somatosensory cortex. So just to summarize this talk, brain imaging tools can be used to look at different aspects of brain function. Function MRI looking at blood flow and blood oxygenation, but they must always be looked at in the context of behavioural measures as well. So asking volunteers or patients how painful is their experience. Function MRI has become increasingly popular in recent years and more available in universities and research centres. But EEG and MEG offer a much faster view and a more direct view of neural activity because of the electrophysiological nature of the recording. Finally, I'd just like to thank my former colleagues at Oxford University, Professor Irene Tracy and John Brooks, for some of the slide materials in this talk. Okay, this is part 3 of 5 talks on neuroimaging and human pain. And my name's Richard Wise. I'm from Cardiff University Brain Research Imaging Centre, working on, among other things, function MRI to examine pain in chronic pain patients. So in part 3, we're going to look at imaging experimental pain in humans. So a lot of what we know about pain, a lot of what we've learnt in the last few years from neuroimaging techniques has been from healthy volunteer studies. So experimental pain stimuli, heat, for example, applied to the skin to look at the effect of that on brain activity. So I'm going to describe to you a couple of experiments that we've done in the past looking at thermal pain and analgesia, and then another experiment in which we modulated a particular component of the pain experience. That's the anticipation to a painful stimulus. And then I'll just raise the question of how pain-specific the brain activity is that we observe. So one of our early studies, when I was working with Professor Irene Tracy in Oxford, was to examine analgesia with an opioid, potent mu-opioid agonist, remifentanil. And our aim was to look at modulation of the pain system. We wanted to examine the role of function MRI as an objective marker of the pain experience to compare with this, the subjective experience of the volunteers themselves. We wanted to look at the regions of the brain associated with pain and the regions associated with analgesia. So how activity in those pain regions was modulated by analgesia. In the long term, this is helping us to look at novel therapeutic strategies for pain. We also wanted to identify a function MRI dose-response relationship, as we call it. So the relationship between drug concentration and the functional MRI pain signal that we measure. So we used healthy volunteers, a phasic thermal pain stimulus, and 4 different doses of this intravenous agent, remifentanil, delivered using a computer-controlled infusion pump within the MRI scanner. We scanned 7 normal male subjects. In those days, in around the year 2000, that was a reasonable number. These days, people realise that we probably need larger numbers of subjects than that in a typical functional MRI study, 12, 15, 20, for example. However, the principles of the experiment still remain. So we need to apply this phasic thermal pain stimulus. We produced 14 stimuli to the back of the volunteer's hand using this thermal pain device, an etched copper plate. Those stimuli had a gap of about 60 seconds in between to allow the skin to cool down. They were felt as painfully hot, around 8 out of 10 on a scale, but they were short in duration, so volunteers knew that there was their skin was going to come to no harm. At the end of the session, we asked them to rate the intensity on a numerical scale. And then, for reasons I'll explain in a moment, we included a simple visual checkerboard stimulus to also stimulate the visual cortex in a phasic manner. And I'm just going to summarise for you the imaging markers of pain which we produced from that experiment. So with a pain intensity of this phasic thermal stimulus of approximately 8 out of 10, we produced this what is now a familiar network of brain regions, including the primary sensory cortex, S1, secondary sensory cortex, S2, insular thalamus, and brainstem regions. As we increase the concentration across sessions, 0.5, 1, 2 nanograms per mil blood plasma concentration, we can see a progressive decrease in the pain intensity score shown on the right-hand side, and a decrease in the amount of activity that we see in the brain associated with that painful stimulus. So we appear to be identifying an analgesic effect. It looks as if we're turning down the temperature on the stimulus from the volunteer's point of view. Now, we went on then to quantify this pain-related activity in these different brain regions, including anterior cingulate, periaqueductal grey, sensory cortices, insular, and thalamus. And in all of these areas you can see fairly robustly a decrease in pain-related activity, particularly in the insula. S1 activity is less robust and depends to some extent on the area of skin that's stimulated in the experiment. Now, the distribution of pain-related activity turns out to be quite similar to the pattern of regional opioid binding within the human brain, and a subsequent study has demonstrated this in 2006. The perceived pain intensity decreased, but how do we know that these reductions in brain activity are actually associated with analgesia and are not some global vascular effect, for example, of the opioid that we've used? Well, this was what the visual stimulus was included for in the experiment. Visual activity was also elicited as we increased the concentration of remifentanil across different scan sessions, and what we found was that the amplitude of the response to a visual stimulus was not decreased by the compound, suggesting, not proof, but it suggests that the results that we saw in relation to pain were related to the analgesia and not a global effect of the drug, as the drug did not affect non-pain related brain activity. Well, that's quite a basic experiment, involves simple heat stimulus. There are no psychological, no state manipulations of the healthy volunteers involved. However, as we've seen in the first talk, pain is a more complex experience than that. And one of Irene Tracy's students, Alex Ploghouse, was interested in looking at a human model of anxiety to pain. So pain can generate anxiety and anticipation. And this, as we'll see later on, may be an important component also in clinical pain conditions. Now, Alex conducted a study in which he identified that functional MRI could anatomically distinguish brain activity related to noxious stimulation, noxious heat stimulation, but also separately the anticipation to pain. We've extended that study to look at the pharmacological modulation of that anticipatory, that anxiety-provoking period using midazolam, a benzodiazepine. But first I'll describe the experimental paradigm that allows us to dissociate pain from the anticipation to pain. So in 8 male volunteers, we used a conditioning paradigm. We gave them 2 different types of brief thermal stimulus, either a stimulus that was comfortably warm or one that was painfully hot. Now, those 2 different types of stimuli were cued by different coloured lights. So, for example, in this case, the warm stimulus is indicated in advance by a blue light and the painfully hot stimulus by a red light. And then green is the safety signal where there's no stimulus being delivered. Volunteers soon learn the association between the coloured light and the type of stimulus. Then if we compare the period when the light is on before the stimulus is given, we can look at the anticipation of pain to the anticipation of warm and examine what brain areas are involved in that process. So we coupled that conditioning paradigm with the pharmacological or the hypothesized pharmacological modulation of anticipation or anxiety, as we're suggesting. We used midazolam, alpha-2 GABA receptor-mediated anxiolytic benzodiazepine in a randomized crossover study. There was an intravenous bolus of 30 micrograms per kilogram of midazolam, and that's been shown to produce reduced anxiety associated with pain by Andrea Malizia. We used a typical blood oxygen level dependent functional MRI contrast experiment, and I'm just showing you the results from the placebo or saline infusion to start with. And what you can see here are is the activity in response to the thermal stimulus itself. Anterior cingulate, primary sensory cortex, anterior and posterior insula, and thalamic activity, this so-called pain matrix which I mentioned earlier in an earlier talk. And there was no significant effect of the midazolam itself on this brain activity, so the pain activity was intact. However, when we look at anticipation to pain, again I'm showing pictures here of just the saline infusion, the placebo. We activate during the anticipatory period a subset of these pain-related regions, including the anterior cingulate, the anterior insula, and to some extent secondary somatosensory cortex. When we infused the midazolam, these patterns of activity were abolished. So this anticipatory activity was selectively reduced by the midazolam, and that's quantified for you here in terms of signal changes being reduced with midazolam in the anterior cingulate, the insular cortex, and the secondary somatosensory cortex. So this pharmacological modulation has allowed us to dissect a particular component of the pain experience when it's combined with a conditioning paradigm. Finally, I would just like to raise the question of how pain-specific these patterns of brain activity are. In this last experiment, we've begun to identify different components of the pain experience. So are these areas that we're looking at specific to pain? Well, in a famous experiment published in 2003, Eisenberger drew parallels between the pain of rejection, the pain of social rejection, and real physical pain. And you can even argue that to some extent in everyday language, pain also refers to emotional context as well as a physical sensation. Now, in this experiment, volunteers were asked to play a ball tossing game in the scanner. They were told that they were playing with other people. They played on a computer. They carried on with the game, and at a certain point they were excluded from the game by the other players. And at that point, this pattern of rejection-related brain activity arose, which has certain common features with pain activities, as you can see here. And this has been labelled as the pain of social exclusion or emotional pain. And the particular area that arose was the anterior cingulate cortex. Now, this is plausible, and anterior cingulate cortex, but anterior cingulate cortex is also identified with attentional tasks and general stimulus saliency. So there's ongoing research, and ongoing research is needed to identify exactly how specific each particular region is for pain. And it seems that many of these regions of the so-called pain matrix are not specific to pain themselves, but are involved in producing the complexity of the pain experience. A similar study looking at other stimuli which may elicit patterns of pain activity involved empathy to pain. And there's a broad overlap of the real pain network. By real pain we mean the network activated by an external physical stimulus, with that activated when empathizing with a partner or a family member who is also in pain. While we can think of this as empathy and the family member experiencing unpleasant feelings associated with the pain being experienced by their family member, we must also bear in mind that some of these activities could purely be related to the saliency of the stimulus, so the attention-grabbing nature of the stimulus, and more work needs to be done to separate out these different components. Some of that work is now in process. So, for example, Irene Tracy's group in Oxford have been looking recently at imagined pain, and one of the few regions that activates differently in real pain, so a thermal heat stimulus compared to imagining that pain, is the posterior insular cortex. So it could be that the posterior insular cortex plays quite a specific role in generating the perception of a physical pain as opposed to an imagined pain. So just to summarize this talk, we can use a simple thermal pain stimuli, for example. There are other models as well, electrical stimulus, pressure pain in healthy volunteers, to look at pain-related networks. Components of the pain experience can be dissected and modulated pharmacologically. And finally, elements of the pain networks have multiple functions and are not solely dedicated to pain, but encode facets of the pain experience, for example, salience and attention. Finally, I'd like to acknowledge Irene Tracy and John Brooks for some of the slide materials in this talk. This is part 4 of a series of 5 talks looking at neuroimaging human pain. This is part 4, imaging more realistic pain, so dissecting the patient's pain experience. I'm Richard Wise from Cardiff University Brain Research Imaging Centre, where we do functional magnetic resonance imaging of chronic pain. So just to give you an outline of this talk, I'm going to describe the move towards more clinically realistic imaging studies. Previously, we've heard about imaging studies looking at experimental pain in healthy volunteers. I will also talk a little bit about models of pain sensitization, so capsaicin as a way of inducing pain, which is compared with neuropathic pain in patients. We'll look at central sensitization in patients, some of the early neuropathic pain studies, and also some recent work looking at the role of depression, anxiety, and the control that people feel that they have over their pain. And finally, we'll just touch briefly on imaging the placebo effect. So there are an increasing number of studies looking at clinical pain processing, and the number of these is now increasing in recent years as people begin to develop the methods for looking at real pain conditions. Petra Schweinhardt, who was formerly at Oxford University, produced a review in 2006 of pain studies that had been done up to that point and the role of the insular cortex. And there was a broad dissociation between the different types of studies. So the posterior insula seemed to be much more concerned with the experimental pain scenarios and nociceptive pain, whereas the anterior insula seemed to be much more concerned with clinical pain and much more aversive pain stimuli. So these areas are of growing interest in the clinical pain field. But one important aspect of clinical pain is sensitization, and we've begun to explore this using capsaicin. So central sensitization is an amplifier to the pain experience, and although it's known that plastic changes can occur in the dorsal horn of the spinal cord, there also appear to be changes further up the central nervous system in the brainstem, and possibly higher than that as well. So capsaicin has been developed as a model in healthy volunteers, and some of these studies have been performed by Laura Zambrianu, a PhD student from Oxford University. What we can see here is just an overall impression of the increase in brain activity that you see in the bottom row when a volunteer is stimulated with a punctate stimulus, a von Frey hair, which is designed to elicit to produce a noxious stimulation. The increase in that activity when an area of skin that's been sensitized with capsaicin is stimulated, and this is an area of secondary sensitization. So this is outside the primary area of sensitization where the cream is actually applied. So the poking of the skin with this von Frey hair was performed outside but around the area where the cream was applied. And focusing a bit further in on Laura's results, importantly, she found activity in the brainstem, suggesting that the brainstem is playing a role in this sensitization process. And animal work, and now some more of this human imaging work, have indicated the role of the brainstem in mediating top-down cognitive psychological modulation of the pain experience, but also bottom-up sensitization, modulating the influence of the brainstem on the dorsal horn processing, for example. An additional study from the Oxford group, from Mike Lee, used matched forces of punctate stimulation, both in a control and a capsaicin condition, in a similar way to Laura's experiment, in an area of sensitized skin outside where the capsaicin cream was actually applied. And these matched forces, the stimuli were adjusted such that Mike Lee could compare the brain activity patterns for stimuli that were perceived of equal intensity. So the visual analog scales were matched, but in one case there was capsaicin, and in the other case it was a control condition. And when we compare the brain images, what we find is that the crucial differences, the crucial increases in activity, although the perception of pain was the same, lie largely in the brainstem, suggesting a role for the brainstem in this central sensitization process. We've also applied these concepts to a pharmacological study, which I mentioned in an earlier talk, a study of gabapentin. Gabapentin is a compound that's used in neuropathic pain conditions. We used it in conjunction with a capsaicin model in a crossover design with a placebo. Again, volunteers were stimulated with a punctate stimulus around an area of capsaicin sensitization. Functional MRI was conducted following this period of sensitization, and what we found were increases in activity, particularly in the insula and in the brainstem during the central sensitization state, but that this activity was significantly decreased by the application of gabapentin, but particularly in the brainstem. So this seems to be a target for the gabapentin activity. But more recently, sensitization has begun to be explored in patients. And there's a study from 2009 from Oxford looking at the central sensitization in a cohort of osteoarthritis patients. So 20 patients with hip OA were awaiting joint replacement, displaying signs of referred pain. So pain that was extending beyond the normal range across the body of their hip pain, suggesting an enhanced transmission at the dorsal horn, an enhanced receptive field. And it was hypothesized that the descending inhibitory and facilitatory components were modulating this nociceptive processing at the dorsal horn. These patients were carefully questioned with psychological questionnaires. Quantitative sensory testing was undergone, and they underwent functional MRI with punctate stimulation of the area of referred pain. And specifically, the brainstem was investigated for this central sensitization. And what we can see here is a region of activity in these OA patients in the PAG, the periaqueductal grey, increase in brain activity compared to controls in response to the punctate stimulus. And that increase in activity correlated quite strongly with the self-reports of pain in these patients, suggesting, again, this role for brainstem processing in this central sensitization state in real clinical conditions. Functional MRI has also been used to examine neuropathic pain conditions. For example, brush-evoked allodynia from conditions such as post-hepatic neuralgia. In this case, there was a collaborative study in Oxford between Irene Tracy's group and GlaxoSmithKline looking at neuropathic pain and dynamic mechanical allodynia. A clinical examination was performed as well as a functional MRI experiment in which the dynamic mechanical allodynia was provoked with a brushing, and there was also mechanical stimulation on the control site as well. And thermal pain was applied on a completely unaffected site. Now, this work, I'm just summarizing the results for you here of the brushing of the allodynic site, indicated again a role for the anterior insular cortex and also the anterior cingulate cortex in this provoked clinical pain. And importantly, the area of the brain that most strongly correlated with the perceived pain intensity was again this insular region, which we've discussed previously. And this is explored a bit further on the next slide, looking at the correlation between the signal change in the anterior insular cortex and this subjective pain intensity rating. So you can see the strength of the correlation here, indicating that possibly this anterior insular is playing a role in coding this pain intensity. These kinds of studies have gone on to be extended by other groups, and in this study by Gerhard in pain in 2007, they've begun to look at the pharmacological modulation of pain and how functional MRI can play a role in identifying early responses to therapy. So in the top row you can see brain activity maps for the rating of spontaneous post-hepatic neuralgia. So this was an experiment in which patients were asked to continuously rate the pain from their condition, and then the variation in that rating over the course of the scan was used to identify, by correlation, was used to identify those brain regions that appear to be involved in processing the pain signals. In the second row you can see a repeat scan approximately 6 hours after the first application of the compound, when in fact there's been no clinical effect. The patients aren't reporting any improvement in their pain sensation, but the reduction in pain activity seems to suggest that the functional MRI could be an early marker of the drug effect in reducing the amount of pain-related activity going on in the brain. And then finally, in the third row, you can see similar scans acquired sometime later when the lidocaine patch therapy is expected to have had an effect, and you can see a further reduction in the amount of pain-related activity. So those are neuropathic pain studies, but imaging is also shedding light on some of the what we might describe as higher level emotional aspects of the interaction between clinical pain and the patient's environment and general mental health state. So there's been some early work from Petra Schweinhardt looking at the interaction between depressive symptoms and pain in rheumatoid arthritis. And it seems that patients with high depression scores have relatively more tender joints than patients with low depression scores, despite having lower levels of inflammatory markers. So behaviourally, there appears to be an influence of the depression state of the patients. But how is this related to brain activity? Well, the medial frontal cortex activated in response to a painful squeeze of the patient's joints, and that activation was positively correlated with the depression scores, suggesting that this medial prefrontal area may also be involved in the interaction between the pain experience and the depression felt by the pain patients. Furthermore, that mediofrontal activation correlated with further activity in the entorhinal cortex, which, as we'll see in the next experiment, has been associated with anxiety in experimental pain. So this is another study that's been performed by Alex Ploghouse in Oxford in healthy volunteers, and he used again a conditioning manipulation to manage volunteers' expectation of the pain that they were about to receive. So in the high anxiety condition, they were uncertain about which pain stimulus was coming next. If volunteers saw a square, then they were either going to receive a low temperature stimulus or a very high temperature stimulus, which would elicit quite a strong pain sensation. If they saw the triangle, they were guaranteed to only receive a low temperature stimulus. And after several cycles of stimulation, they learnt that the square was unpredictable. It could result in pain or no pain, whereas the triangle was trustworthy and only resulted in no pain. And although the temperature was the same, what you can see on the right-hand side here is that the pain intensity rating was augmented by the additional uncertainty of the presentation of the square stimulus. So the temperature was the same, but the pain rating has increased by virtue of the fact that the subject doesn't know whether they're going to receive something very painful or something not painful at all. This seems to be mirrored in some of the clinical pain conditions which have subsequently been examined. And that exacerbation of pain by anxiety was associated with a hippocampal and entorhinal cortex activity, as you saw in the study where we covaried for depression. Now, another aspect that has been looked at recently is patients' control over pain and the interaction between pain and the belief of control that they have over their own lives. So Katja Weich in Oxford has conducted a study looking at characterizing patients' degree of control and then allowing them the opportunity to modulate an external pain stimulus. So brain responses were examined to self-controlled compared with an externally controlled pain. And prefrontal areas, including the anterolateral prefrontal cortex, showed significantly greater activity when participants were able to stop the painful stimulation themselves, compared to the condition in which the pain was completely uncontrollable. However, those volunteers, those patients that were identified as being as control freaks in the common terminology, do badly when they have no control. And they fail to activate those regions. So this indicates an interaction between the belief in control that you have and the pain that you experience. Finally, for this small section of the talk, there was an interesting study in 2005 looking at functional MRI as a biofeedback mechanism. So patients go in the MR scanner, we process the scans in real time and indicate to the patients on the screen a marker of their pain activity in real time. And this was used as biofeedback, so patients were able to control themselves the activity, for example, in the anterior cingulate cortex, and that correlated with the degree of pain relief that they experienced. So other modalities of imaging, for example, EEG, have been used previously in biofeedback, but that was the first demonstration of functional MRI used as a tool in biofeedback to produce some pain relief. Finally, I'll just give a couple of comments about imaging the placebo effect. And there is now increasing evidence for the central mediation of placebo analgesia, so the effect of expectation of analgesia in reducing the amount of pain that's experienced. So pharmacological blocking of opioids reduces the placebo effect. So the blocking of opioid action with naloxone, for example. But placebos seem to activate the antinociceptive networks and seem to have a shared neural network with opioid analgesia, for example. As illustrated in the following study from Petrovic, published in 2002, on the left you can see the main effect of administering opioids, and this is in fact a positron emission tomography, a PET study, showing that the opioids tend to activate regions in the brainstem, anterior cingulate, at least along the midline. And when a placebo session was studied in the same volunteers, again we see this anterior cingulate activity with the placebo, suggesting a top-down control on these pain modulatory networks. So just to summarize this talk, capsaicin has been used as a model for central sensitization in healthy volunteers. Imaging reveals the brainstem as important for central sensitization, both in experimental and in clinical studies. And imaging, it seems, may provide an early marker of treatment effect, for example, in evaluating new pharmacological compounds. The interaction between depression, anxiety, and belief in control of pain is being explored currently, with implications of the prefrontal cortex in that kind of processing. And the prefrontal cortex seems to be involved in maintaining and amplifying this experience of chronic pain. And we'll see in the next talk how there are also structural changes in prefrontal cortex in chronic pain conditions. And finally, the placebo effect as a top-down control mechanism seems to share similar networks as those engaged by opioid pharmaceutical compounds. Finally, I'd like to just acknowledge Professor Irene Tracy and John Brooks for some of the slides in this talk. This is the fifth talk on neuroimaging of pain in the human brain. This is part 5, the latest developments in the field. And I'm Richard Wise, the Director of Functional MRI at Cardiff University Brain Research Imaging Centre. So in the previous talks, we've seen how useful neuroimaging techniques can be for investigating mechanisms of pain, central sensitization in the brain, for example, and we've explored some of the early research studies that have been done on real clinical pain conditions. But what's on the horizon and what's being developed at the moment? Well, we hope, naturally, that future developments will bring greater clarity and improved treatment in the field of pain. Naturally, it's a long research process, but in the last couple of years, it's been discovered that there are potentially structural alterations in the brain, changes in density of grey matter, whether those are causative or a consequence of chronic pain conditions is not yet well known. We're now beginning to be able to measure the chronic perfusion state of the brain non-invasively using magnetic resonance imaging techniques to look at chronic pain. A technique known as diffusion tractography, looking at the connections between grey matter regions in the brain through white matter, is allowing us to look at how the brain is wired up. Positron emission tomography gives us a window into receptor function and receptor binding in the human brain. And finally, an exciting new area of functional MRI is spinal fMRI, allowing us to look all the way from spinal activity through brainstem and higher on up into the brain itself. So first of all, I'll talk about structural alterations in the brain, and in particular in grey matter. Now, in 2004, Ariana published a study in the Journal of Neuroscience indicating that chronic back pain is associated with a decrease in prefrontal and thalamic grey matter density. And we've seen in the last talk how prefrontal activity over short time scales seems to be associated with factors such as depression, control and anxiety in pain patients. So Ariana found a 27% decrease in dorsolateral prefrontal cortex grey matter and also in contralateral thalamic grey matter. Does this represent neurodegeneration in response to the pain condition, or is it causative for the pain condition? We're not yet sure. There have been further studies in the Journal of Neuroscience looking at the accelerated loss of grey matter in fibromyalgia patients. And this indicates something that's similar to a premature aging of the brain. So looking on the left, we have a graph of grey matter, the amount of grey matter, and total brain volume. And what we can see is that grey matter volume seems to decrease faster in those patients with fibromyalgia than it does in healthy controls. Another study by Geha in Neuron 2008 looks at chronic regional pain syndrome. Again, regional grey matter density is decreased in chronic regional pain syndrome, but most prominently in the younger patients, and it seems to be related to the pain characteristics. So the series of graphs here indicates in different regions, for example, ventromedial prefrontal cortex, and also anterior insular medial prefrontal cortex, indicates a decrease in grey matter density compared to controls, which appears to correlate with the duration of the experience of the pain condition, suggesting perhaps that the pain condition is resulting in this loss of grey matter volume within the cortex. Whether that grey matter volume can then be recovered with treatment is currently not yet known. The chronic perfusion state of the brain, we are beginning to learn, can also be a marker of chronic pain. So in the second talk, we explored the methods behind functional MRI, and we saw how the transient bold response, the transient increase in cerebral blood flow, is a marker of acute pain. However, we now have techniques, non-invasive techniques, in the MRI scanner which allow us to measure perfusion over the time course of minutes and then to compare that perfusion from day to day and from month to month. This is known as arterial spin labeling and gives us a measure of the brain state. The technique works by magnetically tagging blood as it flows up through the neck into the brain. We record the arrival of this blood in the brain, and the image intensity that we see gives us a measure of the amount of blood that has got to each brain region, or the cerebral blood flow. And we can produce maps like this, where the brightness of the colour indicates the amount of blood going to that particular brain region in mils per 100 grams of brain tissue per minute. So you can see, as we would expect, there's much greater perfusional blood flow to cerebral grey matter and deep grey structures than there is to white matter, which has a much lower metabolic demand. We can zoom in on particular slices here and pick out some of the structures, for example, insular cortex and sensory cortex, that we are interested in identifying the state of in a chronic pain condition. Now, very recently, the first studies have been published looking at pain models with these perfusion techniques. And this is a study of muscle pain in healthy volunteers, pain lasting several minutes, with the injection into the muscle of a hypotonic solution causing a significant pain sensation. And we see increases in perfusion over the course of a few minutes in the insular cortex, the thalamus, and also the mid-cingulate. Some of these regions are in common with the acute pain activity that we've seen in experimental pain earlier on, and also in the clinical pain conditions. Now, interestingly, when we look at the time courses of perfusion responses in these particular brain regions, and we get an increase of perfusion of about 10%, the response lasts, for example, for 10 minutes, although the pain lasts longer. So there may be a short-term adaptation of the response in these different brain regions, something to explore in future. We ourselves have been looking in Cardiff at the modulation of cerebral blood flow by the administration of opioids, this remifentanil, mu-opioid analgesic agent, which I've described in previous talks. We examined cerebral perfusion before infusing the drug, during the infusion of the opioid, and then following the washout of the drug once the effect had worn off. We were able to identify very focal, very specific regions of brain perfusion which were increased, shown in red and yellow here, and decreased, shown in blue. And the blue regions are the putamen and globus pallidum, which may be related to some of the sedative aspects of the opioid infusion. But the red and the yellow regions seem to compare very well with the earlier brainstem related activity that we've seen in the central sensitization and chronic pain conditions. And opioids are known to have an effect in the brainstem. So this perfusion technique is allowing us to look at the local action of the drug without applying an external pain stimulus. And again, some of these regions that we have identified where there's an increase in blood flow in response to the analgesic drug administration correspond well with the previous PET studies on opiate receptor binding. Diffusion tractography is another MRI technique which allows us to look at the connection of one part of the brain to another. So information is transferred between grey matter regions amongst these networks along white matter tracts. Diffusion tractography, and here's an example of representation of the cingulum bundle. Diffusion tractography is based on the physical phenomenon of water diffusion being preferable along axons rather than across them. So there's a natural tendency of water to diffuse along the axons, and we can sensitize our MRI signal to this diffusion. Having done that, we're then able to identify in which direction the white matter tracts are pointing, and to track from one grey matter region to another grey matter region through these major white matter tracts in the brain. Now, it's hypothesized that some of these white matter tracts may reorganize with reorganized brain function in chronic pain conditions. This is something that we and other groups are currently investigating. There have been recent studies looking at the connectivity of the nodes of the pain networks involved in generating the pain sensations. And there was a recent study in 2006 using diffusion tractography, diffusion tensor imaging, known as DTI, looking at the connections between the brainstem and prefrontal cortex, suggesting or providing evidence for this top-down influence of prefrontal cortex on brainstem and the upcoming pain signals from the spinal cord. Positron emission tomography itself shouldn't be forgotten as a very useful technique for interrogating specific receptors and the networks engaged in that receptor activity. So A study in 2004 looked at diprenorphine binding. That's an opiate receptor binder, and there was a widespread loss of opioid receptor availability in post-stroke central pain, suggesting a dysfunction of this opioidergic system. An additional study in 2007 again looked at diprenorphine binding in central pain, suggesting a reduced opioid receptor binding potential in the hemisphere contralateral to the body site affected by the central pain condition. Now, it's not known whether this is due to endogenous opioid release, trying to dampen down the pain experience, or dysfunction of the pain experience, but the essential point being that PET gives us an idea of the function of specific receptor types within the pain system. And finally, one of the most exciting areas in functional neuroimaging of pain is spinal function MRI. This is technically challenging because of the small size of the spine, the motion of CSF, cardiac and respiratory motion associated with the spinal cord. This is currently being attempted in centres in Italy and in Oxford and in NIH in the US. And these slides are courtesy of John Brooks in Oxford, who's working on this project and has begun to be able to identify plausible regions of activity within the spinal cord which correspond to peripheral noxious stimulation. So punctate stimulation of the C6 dermatome has revealed ipsilateral activation at the C7 nerve root, the entry point for where we would expect the stimulation to show up. Why is spinal fMRI useful? Well, we need to visualize the generators of central sensitization. It will be useful in future to compare the signals in the brainstem with the plastic changes in the spinal cord in central sensitization. Brain imaging reveals the end result of nociceptive drive, so the top-down modulation or facilitation. Whereas we know there are also, from animal experiments, there are also spinal changes in pain processing. And finally, here's an example of left and right hand stimulation in spinal fMRI, showing opposite activation on opposite sides of the spinal cord, and the necessary work that needs to go into cleaning up these noisy signals from this small region of the spinal cord of which we're interested in. So just to summarize, with these newer or alternative imaging techniques, we're able not just to examine dynamic function, but also chronic perfusion and the state of the brain and how the long-term structure of the brain is altered in chronic pain conditions. We can begin to look at the connectivity of one brain region to another and the communication between brain regions. These brain regions in these pain networks are not isolated. They're constantly communicating with one another. Positron emission tomography produces a receptor level view of pain activity, while MRI is able to cover the brain, the brainstem and the spinal cord, and in future we'll be able to look at plasticity at all levels of pain processing. Finally, I'd like to acknowledge Professor Irene Tracy and John Brooks for some of the slide materials in this talk.
Next time, I will explain about anesthetics.